So I think one key thing, I'm not obviously going to go through this, but a key thing for those who don't know me is that my primary appointment is in the College of Nursing, but I'm not a nurse by training. I'm a computer scientist and engineer, and so I have a bit of an unusual position. And much of what I do is in healthcare related things, nursing healthcare related things. Some of it is less so or not. So you can just see here, there's a lot of stuff I did that's more basic engineering related things, including signal processing and a variety of other sort of low-level engineering things. But I love where I am and what I do in terms of healthcare. So I've chosen three things to share with you today at a relatively superficial level, a teaser, kind of skipping a stone across the water, in three things that are related. As a sampling of those things I do in healthcare. First has to do with patient simulators. I think we can all probably agree that we would prefer that nurses and physicians don't learn on us when we're in need of their care. We would prefer that they learn and they would too, in circumstances where they can't harm the patient and where we're not harmed. So this is work that I've been doing with, you can see people listed here. The key thing is, and I'll give you a little teaser here, physical form plus a virtual patient. So the idea is you can walk up to one of these devices and interact with it as if it was a real patient. So a little context here, three typical mechanisms people use for traditionally or conventionally for simulating patients. The first are real people who are not just actors, but they're trained to be part of the training. So they're experts in the training. So for example, this woman here who has some fake wound on her leg, it seems, or I guess that's a sensor. But anyway, so the patients can be dressed up to seem wounded, they can pretend to be wounded, they can exhibit all of the anxieties and everything that a real patient would, and the trainee, the physician or nurse, interact with them. They're gold standard in terms of their behavior. Of course, they can't exhibit certain pathologies or certain symptoms that they can't because they're healthy, but they're expensive. They're expensive not just money, but in terms of time and getting them in one place and everything. But they are the gold standard. There are things called, people refer to as mannequins, literally in air quotes. They're robotic, sort of like dime store mannequins or something, if you're old enough to know about that. So you dress them up in clothing or whatever, and they do for training, for simulating. But they'll have things like robotic throat, larynx. They can open and close their eyes. They might have a speaker inside the mouth so that the child, for example, in this case, can cry out and say, I'm scared, or something like that. You can maybe feel pulse on their wrist and things like that. So that's very physical. Then the third class would be something people typically call virtual, which is really computer graphics on a screen, typically. Sometimes in a head-mounted display, but typically on a screen. And so you can see the virtual patient allows you a lot of richness and flexibility of, like, you can change the skin color, the gender, you can change like that. You can change, swap patients, swap conditions, bring on conditions, bring out conditions. With the mannequin in the middle, right, the skin color, everything about the mannequin is what it is when you buy it. You can buy different skin colors, mannequins are different skin colors, but whatever you buy, that device is what it is. And the same is generally true for the humans, of course. So what we've been doing is, this is, by the way, the order of the three things I'm showing you are sort of in levels of maturity. So this is the most mature, then the second thing I'm going to show you is middle, and then the last is the least mature. So this is funded work from the National Science Foundation, Office of Naval Research early on. And what you see here is what we call the bed, or a frame. It's simulating like a hospital bed, this metal frame with a bunch of equipment in it. And then on the top of it, where my nursing colleagues, Professor Desiree Diaz and Mindy Anderson, are interacting with the child, they have the ability to reach out and touch. So it's actually shaped like a human. It's plastic shell, we call it, with projected imagery from below. So the projected imagery is virtual, just like the virtual patient stuff I showed you before. So we can change the skin color, the wounds, we can make the patient animated. They can look and turn and talk to you or cry or do all sorts of things. But it's also touch enabled, so that you can reach down, like I show in the lower left here, and like grasp on the lips or pull down on the eyelid or something like that. So it senses you're touching the surface. You could pull on it or push on it or do something, and you'll see the graphical changes as you would with a human. Then we also have things like pulse actuators, so you can feel, like if you put your hand near the wrist or the neck or the groin or somewhere else, wherever we put those, you can feel pulse. And we have sound, of course, and We have the ability to sense, like I said, we were touching. A key thing about this is that shell on the top. This whole paradigm is designed, the idea is that the complexity is below the shell. The shell is itself just plastic, simple. So you could take off the shell, replace it with a different shell. So you could have a different shape child, different gender, different anatomy. You could have a dog if you wanted. You could have whatever you wanted. But all the complexity, the calibrated stuff is embedded in the frame. So where are we right now? Sort of things we're looking at in the near term. Our NSF grant is to some extent winding down. We have an extension and we have an REU for students, so we're doing some things. We want to figure out better ways to do the shells. They're relatively expensive because of the optical properties and the tactile aspects. Better integration with other simulators or better simulation integration, some better live interaction mechanisms, and we want to, the touch sensing is sort of done at the level of a PhD student's dissertation. It's not ready for prime time, sort of, use by others. So that's something we'd love to do. Long term, we've been talking to people about integrating physiological engines, right? So when the patient's blood pressure drops, you would see the effects and things like that. And whether you put pressure on the wound affects the blood pressure, which affects the appearance of the patient and their vital signs and things like that. And then, some out of the lab demonstrations and eventually commercialization. All right, number 2, moving on. Brand new topic, now for something completely different. Around the time of COVID, and of course we're all watching the news, and I was watching all of these families and people who are separated from their loved ones, and their loved ones are dying alone. Their loved ones are alone, the family feels helpless, they can't do anything. They're not allowed to go see them, they can't touch them, the best they can do is FaceTime with them or video with them. So this was born out of that. And a key thing, if you don't remember anything else about this, one of the key things that I really like about this is that here it says being touched and touching, therapeutic for all. The idea is that we could all imagine that if someone could touch our forehead, it might feel good to us, but sometimes we don't realize that it's actually good for the person who's touching your forehead. It allows, for example, family members, if they could touch you, to feel like they have some control, like they're doing something. They're not quite as helpless as they would be if they're completely separated from you except for televideo. So you see in the lower right here, the idea is you have, and I'll show you a picture in a second, like a headband. I mean, we could do this on wrists, arms, other places. I could get into that later if anybody wants. But in this case, patient wears like a headband, and the family member somewhere else sees the video of the patient and can like rub their head. They can rub on the head on the tablet, and the patient will feel that on their head, and the family member will see that the patient is feeling it. So there's a bit of a feedback loop there. So we have a prototype. We've done some controlled experiments, and this, by the way, this is all undergraduates. This is collaboration with mine with Ryan McMahon, Professor Ryan McMahon in computer science, and the 3 students we're working with primarily are undergrads, and they're amazing. They're fabulous. So the controlled work on the right here, that is like just measuring, can they feel like different patterns we would input into the computer, and on the sort of yellowish pad on the right is their hand drawing of what they felt, and on the left column and the swiping on the far right of the diagram on the far right is what we sent to the system. So it works pretty well, and you can see it sort of in operation on the left here. Near term, we're trying to harden the prototypes because we have some nursing colleagues, Professor Frank Guido-Sans, for example, who works in an ER, works at a hospital regularly, so he's going to see if he can get some colleagues to try this out and get their feedback on it, so just a demonstration to them. Trying to improve the overall usability, looking at a variety of things, worried about sterilization, things like that. Longer term, we'd love to be able to do something that's contactless, and I could talk to anybody who wants to later. There are lots of mechanisms that seem promising in this respect, so that you could actually, the patient could feel touching on their body and could see things in 3D in front of them without anything mechanically touching their body. There's some pretty cool stuff there. All right, the last thing for me here, assisting patients, and this is the least mature. Remember I said the most mature, which is the physical virtual patient bed stuff. Sort of medium is the tactile telepresence that I just talked about, and this last part, assisting patients. This is at the point of, I'll show you in a second, but we have 2 pending NSF grants. One is for actually doing some work, a long-term, a 3-year grant for doing some work developing the technology in with the computer science technology, like Professor Kiedis Konkar and Professor Pamela Wisniewski and Ben Locke and myself. So technology stuff, working with Teresa Daly and folks at the Center for Autism and Related Disabilities, led by Professor Mindy Anderson from nursing. So it's a very multidisciplinary team focused on autism as a driving problem. So, what is it we're trying to take care of? What we're trying to think about is, you can see the buzzwords here: continuity of care, health disparities in individuals and families. But let me just say, before I go to the next slide, any of you who have, I'm not a medical person, but I would say chronic conditions for, say, a family member at home, or even maybe yourself, we're all familiar with, you go and you visit the, it might be the nurse practitioner or the physician or whoever it is, you have an appointment with the professional. If they tell you what to do, you go away. 6 weeks later, 8 weeks, whatever it is later, you come back again and they go, did you do that? What are the results? And it's like you have very little interaction typically in between. You might have needed help. You might have forgotten how to do it. You might not have done it right. You might have needed prompting. This is especially true for families with, say, children with disabilities who need continual therapy. And so the parents are left sort of like, okay, I listen to the professional. They tell me what to do. Now I have to do that every night, every day. I have to multiple times a day, and it's stressful and it's hard to remember what it is I do. So it's that sort of, what we're trying to do is bridge that episodic sort of every so often you meet with the professional and with nothing in between, to cover a bunch of things. So the idea is that you would have something like an Amazon Echo Show. You look in the middle of right in the middle, smack dab in the middle of the slide there, labeled C. It's sitting in your kitchen counter maybe. This is just one example of how this could be realized. There are many others. And there's an agent there. And part of the idea is that this agent is going to be around all the time in your house. This is a graphical character who's intelligent, who can talk to you, listen to you. You've permitted into your home, you've given it access because you want the benefits. So the privacy issues to some extent are assumed to be mitigated here because you've chosen to have this in your home because you need the help and you want the help for your child. So this is one interesting thing here from agents is a lot of agents we have right now, like if you think about an Amazon Echo, they're very transactional. I ask it, what time is it? It tells me what time is it. I ask, what's the weather? It tells me the weather. That's it. So here the idea is that this character has a life of its own. So it's off, it's interesting, it's busy, it's doing things. When necessary, it can be proactive. I walk into the room, it can ask me, hey, have you brushed your teeth? Susie brushed her teeth, have you brushed your teeth yet? Or something like that. So convince kids to do the things they need to do. Physicians, nurses, professionals can task the agent with things. Like if the physician says he needs to count to 10 times a day. So, that's the task. And then the agent can try and achieve that. That's the idea here. Again, this is very preliminary, but that's the idea here. And then we can have longer term goals too. And as I said, getting away from the transactional relationship and making it more relational. That is, you get to know the agent gets to know you, and you feel comfortable with the agent kind of guiding you in doing things. So right now, as I said, we have a couple of pending grant proposals. One is in smart and connected health, and the other is in communities, which is larger. We're talking to, our collaborators are in Orange County, Advent Health, and we're talking to people in Orlando Health, and all over the place. We're trying to bring a lot of people links, so there are a lot of other related proposals on campus. So that's a lot of fun. Really enjoying that. Yeah, longer term, lots of interesting things. Maybe smart speaker technology. This is nicely aligns with what many of us have in our homes. And I've got some other longer term goals here. And with that, I will shut up and take questions if there's time, or allow the next person to move on.